Good afternoon, everyone. Thank you so much for coming to our prenatal modulator treatment session, PROTECT for short. I'm Sylvia St. Petery. I'm a pediatric pulmonologist at the Medical University of South Carolina in Charleston. And I have had the distinct privilege of caring for several families who've been on a prenatal treatment journey. And in the avenue of that, created a registry to help track outcomes for infants who are ETI exposed with this pathway. So I'll be sharing some data I have on that later in the session, but I'd love to also introduce our co-chair, Andrea Rowe.
Hi, everyone. I'm Andrea Rowe. I'm an OBGYN with a specialty in family planning. I'm at the University of Pennsylvania, and I'm sort of the local GYN go-to for the CF Center at Penn, and I'm excited to be moderating today. We just have a couple of learning objectives here, so just putting them up on the screen to let you know what to expect. So we're hoping to review what's known about in utero exposure and postnatal treatment with CFTR modulators from animal models, and then discuss some existing data in people as well, and then also review some perspectives from CF community members who have experience taking CFTR modulators during pregnancy or during breastfeeding. And this is probably a good disclaimer that all the opinions shared today are of the individuals who are presenting and not the CF Foundation. All right.
And so to kick things off, we have the great privilege of having not one, but two family experience voices to discuss the prenatal treatment sphere and what life has been like with that exposure. And we have both Lacey Norton joining us in person and Stephanie Marquardt, who is joining us virtually, but in spirit with us very much. Lacey, I'll introduce first. She's a mother of three, two daughters and a son with cystic fibrosis. When she's not caring for her family, she volunteers at her children's school, helps coach her girls' soccer teams, and loves catching up with friends over coffee and planning family adventures. Thank you so much.
Oh, that's perfect. Thank you so much. Okay. Yeah. Oh, there he is.
Spoiler alert.
Thank you guys for that introduction. And hello, everyone. As you now know, I am Lacey Norton. I do have two beautiful, healthy girls, ages 8 and 5, and one very handsome, special boy, who is now 2, and he was flagged for cystic fibrosis at 1 week of age. Like every family facing a rare disease diagnosis, our story is unique. But today I want to share about how asking questions, a collaborative healthcare team, and access to the right information has had a positive result for our son. Starting with the decision I made while breastfeeding. My pregnancy had been smooth and my ultrasounds normal. I even had a repeat ultrasound at 35 weeks because of my body, and the results were unremarkable for our infant. By the time you're in child number 3, you recognize the nurses, your OB feels like family, and you just kind of expect things to go as they have before. Our baby was born 1 week early, healthy and content, a good-sized newborn who wasn't too interested in feeding at first, but was otherwise seemed perfect. At 24 hours, we were still waiting for that first meconium. When it didn't happen, we tried a glycerin suppository, and shortly after, there it was. All was well. A few signatures later, and we were home with our newborn, tired, happy, but ready to begin life with a family of 5. Exactly a week later, life shifted. I remember it very clearly. I was in the parking lot of our local grocery store, loading groceries into the back of my minivan that was freshly purchased, when my phone rang, and it was our pediatrician herself. After 6 years with her practice at this point, that alone made my heart drop. She told me that our son's newborn screen had been flagged for cystic fibrosis. His IRT was over 200, and further testing confirmed that he carried 2 copies of the F508del mutation. We were told to wait a few days for the CF clinic to call and schedule an appointment, and we would learn more. But as any parent here knows, the waiting is unbearable. So the next morning, I couldn't help myself. I picked up the phone and called the clinic myself. By 13 days old, our baby was in his first CF clinic. We left that visit with enzymes, ADEC vitamins, salt, a few percussor cups, and a brand new understanding of what life might look like. Those first few weeks were incredibly heavy for my husband and I. We grieved for the future of our newborn son. Thankfully, we were surrounded by support, family, friends, and soon a CF community. Through that network, we quickly learned a few new words. Modulators, Trikafta. I think it took like 2 days after the foundation found out about us to learn those words. At the time, it sounded a little too good to be true and possibly a little out of reach. But we were cautiously optimistic, and naturally we had to know more, and soon it began to feel urgent. By the time our baby was a month old, we were messaging our care team asking, where are Trikafta trials happening for children under 12 months old? Could we get access anywhere else, Europe, Australia? What connections do we have to get closer to these modulators? With Orkambi eligibility at 1 year of age, we knew we had hope right around the corner. But we were asking ourselves what we could do now. Then one day, that November, our CF coordinator walked into clinic smiling. She said, I've heard in several recent case studies that mothers have taken Trikafta through pregnancy and continued through breastfeeding. I immediately thought of you. Honestly, I was flattered. I had not easily, but successfully, breastfed or exclusively pumped for my 2 daughters. And our son had thankfully taken to breastfeeding without a hitch. This idea that I could take a modulator myself and possibly pass some benefit through breast milk felt like a huge breakthrough. A door opened that we had been knocking on for months. Over those next few months, I worked closely with my primary care provider and our son's clinicians. There were many questions, a few unknowns. We gathered lab work, completed my eye exam, and settled on a diagnosis, CF carrier. Our insurance approved. And by February, I started Trikafta, while of course continuing to breastfeed. For me, the side effects were pretty minimal, a few intense headaches a month, and an odd full feeling on the evening dose at times. But otherwise, I tolerated it well. For our baby, the results were remarkable. At 2 weeks old, his pancreatic elastase was below 40. By 1 year old, 5 months after I had started taking Trikafta while breastfeeding, it was over 250 and has continued to climb. His sweat chloride at 3 months of age was in the mid-80s. When repeated at 18 months of age, it was in the low 60s. Soon after those improved pancreatic results, we weaned off enzymes, and we haven't looked back. No more enzymes and applesauce on our van console, side tables, or the side of our rocking chair. We've actually retired applesauce from our pantry completely. When he turned 1, he became eligible for Orkambi, which he tolerated pretty well. By 18 months after discussing it with our care team, he began taking Trikafta directly. He had already reached the weight range for that starting dose, a positive result in itself. Today, at a little over 2 years old, he does continue his vest treatments, known as beep beats in our house. He takes Pulmozyme and vitamins on a daily basis, but ultimately he's a curious, chatty, and thriving toddler. Now, it's recommended to not ask the what if questions, but I think in this group, I hope these are the questions that we keep asking. What if my husband and I had found out we were carriers? Would we have found a way to start modulator therapy earlier? What if I hadn't been given the choice to take modulators while breastfeeding? Would we still be dosing enzymes before every meal and before every snack? Would our son have gained the weight necessary to make a smooth transition from Orkambi to Trikafta at just 18 months old? I don't believe our experience has to be exceptional. I believe we were given the right information at the right time and that we were surrounded by family and clinicians who encouraged curiosity, collaboration, and kept pushing and positive. I truly think this could be more family story if those same pieces align. I realize that every situation is different and therapies continue to evolve and improve. Thank goodness, and thank you to so many of you. But there are options now, and my son has benefited from us taking them. So we've not been on this journey in a vacuum. To our CF care team, thank you. You're here, you know who you are. Thank you for all the questions answered and the messages that you've entertained. And to you, thank you so much for asking me to come speak and tell our story. Thank you, guys.
So just as a point of the structure of our symposium, we'll be holding all of the questions for the presenters until the end of the speakers. So I have the privilege of introducing another spectacular speaker for us. Stephanie Marquardt will have a video shared with us. She's a mental health therapist, mother to her CF fighter Hazel, advocate for awareness, research, and support in the cystic fibrosis community. In her spare time, she enjoys hiking in the Smoky Mountains, playing around with the banjo, and soaking in all of the toddler snuggles. Irresistible based on the picture.
Hi, everyone. My name is Stephanie Marquardt. I'm so excited to be here today. Thank you for the chance to share my story from afar. But my name is Stephanie Marquardt. I am a mental health therapist, a carrier of cystic fibrosis, and most importantly, the mother to our incredible daughter, Hazel. Hazel is now 16 months old, and she was born with cystic fibrosis. She's been receiving ETI treatment since 27 weeks gestation. So the way I first learned about the option of treatment in utero was actually never directly from a medical provider. I was 20 weeks pregnant when I had the anatomy scan, and my OBGYN found some brightness in the bell. She came back and said, hey, it's probably nothing, but let's do the genetic testing just in case. So that took 4 weeks to get those results back. And at 24 weeks pregnant, my husband and I received the very hard news that our daughter would more than likely be born with cystic fibrosis. There was a very high chance. I think it was a 9 out of 10 chance. CF was brand new to us. We didn't know what CF was. Certainly didn't know that we were carriers. So this was a very steep learning curve into a whole new world with a whole new language. But even in that initial phone call with our genetic counselor, I remember asking like, okay, what can we do? How do we get ahead of this? As a mental health therapist, I very much come from an approach of prevention over intervention when possible. And she was saying, there's really nothing you can do at this point in time, but thankfully, your daughter will qualify for modulators when she's old enough. But at this point in time, just hang tight. So of course, I sat on that information for a weekend and was Googling and reading what I did not know was really outdated information. And so came back that Monday considering a termination of the pregnancy at 24 weeks gestation, which is not something, while I myself am very pro-choice, I would never have imagined myself considering that or being in that position at 24 weeks. It's not something that I was taking lightly. But I let our care team know that, hey, this is something I'm considering. And it wasn't until then that my genetic counselor offered to put me in contact with another mom who was at the same clinic with the exact same care team here in our town. And this mom was the first time, it was through this mom that I heard about for the first time of the possibility of treatment in utero. So this mom is a CF carrier, and she was pregnant with her second child at the time who had confirmed CF diagnosis, and she had started ETI treatment in utero for her child. So from that moment on, I said, I will have what this mom is having. And so I came back to my OBGYN who was actually also her OBGYN. And I said, I would like, I advocated for a referral to the adult pulmonologist. And after a bit of hesitation, they did give me that referral. And the adult pulmonologist, thankfully, was very quick to prescribe ETI. Um, but he warned me, he said, you are only a carrier, you do not have cystic fibrosis. This is not FDA approved yet, so there's a really good chance that we won't get approval. And if that's the case, then that'll be kind of the end of the road. Well, I am not someone who accepts no for an answer, especially when it comes to my daughter's health and well-being. So while he was fighting with insurance and trying to get approval, we had been denied, I think, 2 times at this point. I was connecting with other moms throughout the world on social media, other carrier moms who had success receiving treatment in utero for their babies. And a couple of physician names kept coming up, Dr. St. Petery being one of those names, where a lot of these moms on social media said, hey, you need to connect with Dr. St. Petery. So I cold called, or rather cold emailed her and said, hey, my name's Stephanie Markward. I'm 24, 25 weeks pregnant at that point in time. We're trying to get insurance approval. And she responded the same day and was kind enough to collaborate with my pulmonologist. And after, I think it was the second or third insurance appeal that we did end up getting approval, it was after it went to a peer-to-peer. So once insurance approved it, I had the opportunity to pay $9,000 to get my first month's prescription. And at that point, I was, of course, just thankful to have access to what I consider to be a very life-saving drug. I will backtrack for a second. So when I got this news at 24 weeks, I did decide to go ahead with an amniocentesis. So I had that at about 24 and a half, maybe 25 weeks pregnant. And those results did, of course, come back to confirm cystic fibrosis, double delta F508. So it was at 27 weeks gestation that I got access to ETI after insurance approval. Started taking it immediately. And within a month, we saw that my daughter's echogenic bowel, her meconium ileus, had almost completely resolved to the point where they said, if we weren't looking for some sort of brightness, we really, there's nothing to see here, really. So that was an immense relief to maybe have some sort of proof that Trikafta was working, that this ETI was working for her in utero. When I was taking it, I had no side effects, which I was very thankful for. And I continued taking it from 27 weeks pregnant all the way through until 2 weeks after my daughter's birth. So when Hazel was born, she continued to receive ETI through my breast milk for the first 2 weeks of her life. And then at 15 days old, we decided to switch to direct dosing. And part of the reason for that is I just wanted to know exactly how much she was getting. With breast milk, I wasn't really sure. And I knew she was getting some, I didn't know how much. So by direct dosing, we had kind of a clear foundation that we were starting from. And she has continued to receive it every day since, from 27 weeks gestation all the way until now at 16 months old. And we will continue giving it to her. We call them at home, they're called her sprinkles, and she takes them twice a day. So when Hazel was born, she was born pancreatic sufficient. Her sweat chlorides were in the low teens. There's no talk of, she's never had any percussion therapy. She doesn't have a vest. She's never had enzymes or needed enzymes. Her height and weight are in the 90th percentile for both. And her newborn screening, even though we had the amniocentesis confirm her CF diagnosis, they do that heel prick, and her newborn screening for CF actually came back negative because ETI treatment was working so well. So of course we are incredibly grateful, and her pediatric pulmonology team, they do a phenomenal job of checking her. We have a sweat test done at each appointment, her blood work, her sputum, her fecal, and of course we check for cataracts frequently as well. So I am very well aware that this is not everyone's story. I'm very, very thankful that this is our story. And I'm not even saying that this is what everyone else should be doing. But I certainly believe that it was the right choice for us. And I'm a firm, firm believer that every parent should be able to make an informed decision. And so that starts with needing to have the information to be able to make that choice. Um, so yeah, that's it. Thank you so much for the opportunity to share.
Next, I have the privilege of introducing Dr. John Engelhardt. Shifting gears a bit, Dr. Engelhardt is a professor at UAB in the Department of Medicine, Division of Pulmonary, Allergy, and Critical Care Medicine, with research efforts currently focused on the study of the molecular and cellular pathogenesis of cystic fibrosis, related diabetes, and lung disease, the study of airway and pancreatic stem cells, the development of ferret animal models for lung and pancreatic diseases, the development of gene therapies for cystic fibrosis with focus on recombinant parvoviruses and their transduction biology. He directs the NHLBI-funded National Ferret Research and Resource Center to assist others in generating and using transgenic models for lung research. Thank you, Dr. Engelhardt.
Well, thanks to the organizers for the invitation. Those two stories were awesome. That's what motivates us scientists in the laboratory. I don't have any disclosures that are relevant to this presentation. So as most of you know, cystic fibrosis is a multi-organ disease. We're lucky to have a number of animal models that develop disease in each of the organs that are listed here. And the in utero severity, although I'm not going to go over in great detail, I guess you can't see my pointer. Huh? Oh, you can? Okay. Although I won't go over in detail the differences between the severity, probably caused by modifier genes that vary between species. But these four organs here, I'll give some stories about the journey we've taken using transgenic ferret models of cystic fibrosis to understand these pathologies and the implications of using CFTR modulator therapy. So when we first designed a model of G551D in ferret, the reason for doing this is on the top. We had generated a CFTR knockout model, very difficult to rear. About 2% of animals, and this is a very large team on these animals, we could keep about 2% alive past 3 weeks. We developed this G551D ferret model by knocking into the genetic locus and then began GILs, which are the moms, on VX770 or ivacaftor. This is one of the most effective CFTR gating modulators. And then we managed to rear about 90% of animals past 3 weeks for doing our study. We would gavage the animals after birth and then feed them orally after that. And so this was our go-to for quite a long time. Now, to remind you, the pancreas is an extremely sensitive surrogate endpoint for CFTR function at birth. It begins in utero. Pathologies begin to occur in all animal models. CFTR functions to move bicarbonate into the lumen of these ducts, which raises the pH and keeps the pancreatic enzymes inactive until they get into the intestine to digest food. So we had developed 3 different genetic models that we were using to study pancreatic disease at the time. The CFTR knockout, as I mentioned, very difficult to rear, but developed this classic fibrotic and cystic disease. These G551D ferrets, we were thankful that if they were reared from in utero 3rd trimester on ivacaftor, that they maintained function within the pancreas. And if they were taken off, they'd lose this CFTR function and get fibrotic. And then a delta F model that we generated, which using ivacaftor and lumacaftor, these are the chemical names, could keep the pancreas mostly protected, as you see here. And then if removed from these drugs, they become fibrotic, as indicated by this blue staining. So some of the studies we did early on were to track the weight of these animals, the G551D animals that were reared on ivacaftor, and then to track the fecal elastase postnatally. And what you can see here is that both heterozygous and homozygous, so this would have one functional CFTR allele, the weight gain was significantly greater than CFTR knockout. And the fecal elastase, however, we were surprised somewhat to see that the animals had to be homozygous in order to retain fecal elastase activity similar to normals. And these other arrows here denote that pancreatic elastase was significantly lower, and then the animals had to be put on pancreatic enzymes. And histologically, this protective level was suggested here by histopathology showing protection or pancreatic fibrosis. And so surprised by the fact that at heterozygosity with one G551D allele, these animals become pancreatic insufficient, we looked at the CFTR levels, and what we found from this transgene that we knocked in and left this selectable cassette in the intron of CFTR, that at heterozygosity or homozygosity, they only had 50% the amount of CFTR. So this was what they call a hypomorph. The expression from the CFTR locus was 50% because we left this insert here. And so we regenerated the model for a clean knock-in. So this had no residual cassettes at the locus. And these animals at heterozygosity maintained CFTR pancreatic function when reared on ivacaftor. And so another very sensitive endpoint for ivacaftor function is meconium at birth. Now, CF ferrets, knockout ferrets, 80% of them have meconium and die shortly after birth, whereas in humans, about 15% of humans are born with meconium. So treatment, this is the hypomorphic model. So treated with one G551D allele, we can see that treatment with ivacaftor at heterozygosity or here at homozygosity significantly protected from meconium. This is the percentage of animals passing meconium at birth. And the percent survival was also increased, with two alleles being most effective. Sorry about that. And so if one draws the analogy for these various genotypes, knockout, heterozygote, or homozygous G551D, this is the amount of CFTR mRNA that would be within them, 25%, 50% here. If you look at the amount of CFTR activity, ivacaftor recovers about 50% of CFTR gating. You're at about 12.5% or 25% activity. And so this cutoff for beneficial effect to ivacaftor of about 12.5% activity is fairly similar to what Gary Cutting historically had determined in the literature based on splice mutations and nonsense mutations, patients that would have relatively normal function in their organs. And CFTR mutations that have partial rescue by highly effective modulators or expression might be similar to the hypomorph. We think that this model might be useful in dissecting that biology. So essentially, if we breed onto the right background, we can get backgrounds of CFTR activity of 25%, 50, 75, or 100%. And I think thinking about clinically useful questions to compare modulator activity to humans, that this model could be helpful. Now, the Delta F508 model was fairly similar. We see about 50% recovery. This is just a short circuit current assay looking at here the Delta F508 homozygous compared to wild type. And if one looks at the effect of ivacaftor and lumacaftor, so this is VX770 and VX809, given to these animals in utero, third trimester, and one can look at the percentage of meconium frequency or 1 week survival, one sees something very interesting that I personally didn't expect. There was, of course, with both drugs, significant protection from meconium and the survival postnatally was actually close to 100%. But just treating the Delta F508 homozygous mutations with ivacaftor alone, which just affects the gating of CFTR, there was a reduction in the amount of meconium and increase in survival, suggesting that the amount of function you needed during this period was relatively minimal. This is just to mark where CFTR knockouts would be 80% meconium and the amount of survival somewhere down around 2.5%. So only a small amount of CFTR activation using IVA alone appears to be needed to enhance postnatal survival. Now, another thing that we looked at was, and this is using the hypomorphic line with G551D, animals treated with ivacaftor in utero, was the protection of the reproductive organs in the male. And these have been known to, in the absence of CFTR, not form properly and lead to sterility in CF males. And what we saw is that VX770 only protected the homozygous animals. You can see here this tube of the vas and the corpus here, and histologically, the epithelium retained here. And so in this particular setting, we needed about 25% of CFTR function to protect this. Now, the other things that we evaluated were postnatally, how long do you have to maintain CFTR modulators in order to protect these kits? And so this is just an example of, we're looking at body weight first and we'll look at survival next, but this is body weight of wild type and CFTR knockout ferrets over the first 3 weeks of life. These are heterozygote G551D animals, the hypomorphic. So there's only about 12.5% CFTR function in these animals on IVA. And what you can see is that removal at day 0 versus up to day 25, significant reduction in weight gain. And this is reflected by a significant decrease in survival. So the earlier that the modulator is removed, the more these animals succumb to pathologies. And there are a number of reasons that this might be that we're interested in. One, when you don't allow organs within the body to adjust and compensate with other channels and other pathways, it's like turning the brakes on immediately at birth, and this is likely harmful when the demand for CFTR is higher. And the other aspect might be that these are very small animals, and that the size of the tubes that have to clear fluid in most of the organs is the cause of pathology in the gut and the intestine and the lung, that these are very small during this window, and that may be more difficult in the absence of CFTR. Now, in some data I obtained from Susan Burkett, where they had developed this very novel human G551D knock-in into the intron 1 of the endogenous rat CFTR gene. So they're able to now study CFTR modulators, in this case IVA. This is an example where they treated animals throughout gestation up to day 21. You can see protection of the vas in these rats. This is just a blood vessel over here where the vas is absent. And also, just like we saw in ferrets, that ivacaftor protected survival postnatally when maintained. So the removal of CFTR modulators at birth following in utero presence there might not be time to compensate with other channel. Oh, I think I went backwards. Sorry. So some of the other things that we felt were important, at least experimentally, we needed to generate animals as quickly as we could to study the progression of lung disease. And some of the things we went through after we developed the G551D animals was to figure out, okay, how early can we remove them from this drug so they can progress like a CFTR knockout, but not succumb to these very early postnatal pathologies. So this is an experiment where we're looking at animals that were taken off VX770 or ivacaftor at about one month where they're taken off at 1 month of life, and we had a group that was maintained on ivacaftor. And what I'm going to talk about are associated pathologies with the animals that underwent this study and what that might mean for potentially human applications of drugs early in life. So the animals that came off, they're probably not surprisingly, we had problems with gut obstruction, rectal prolapse, so the intestine was severely affected, despite the fact that they went on pancreatic enzymes. And a finding that we didn't expect was sort of later in life and pretty much time to about 2 months off VX770. There was severe enteritis and elevated LFTs. So enteritis, this inflammation of the intestine here, you can see all these neutrophils and the villi within the intestine, suggests that very significant damage. And this is just the liver function test, ALT. You can see a rise in the animals that succumb and had to be euthanized, that they had significant elevations, probably because of their hepatic disease and the fact that the liver drains into the intestine. So these animals, this is just another view of this experiment. So we put animals third trimester, kept them on at birth 1 month, took off this group, and then weaned. And now we're looking at fecal elastase in this cohort and what happens over time. And what you can see is here measuring at 1 to 2 months of age, we see the animals maintained on VX770. There's this wide distribution. Most of these animals, 200 as a cutoff for pancreatic insufficiency, are pretty low. All of the animals that were taken off decreased to 0 pancreatic fecal elastase. And interestingly, the animals that were in this group that were classified as pancreatic insufficient at 1 to 2 months of age uniformly increased, suggesting that the pancreas during this time period, this later group was measured between 3 months to adulthood, that the pancreas had this amazing regenerative capacity to reconstitute its acinar cell mass that secretes these pancreatic enzymes. And indeed, if one histologically looks during this time frame, one sees that these modulators, and this is the clean G551D knock-in, so this is 100% CFTR mRNA, maximal 50% protection of activity. One sees that there's fibrosis at these intermediate ages, and I'll just comment in the pancreas at 80 days, or about 8 weeks of age are when ferrets are weaned. So that during this time frame, there's this incredible demand on the pancreas to produce more enzymes to digest the food that they're now eating independently. But then by the time they get to adulthood, the pancreas, that demand, perhaps spread out more across the pancreas, was much more stable. We've also looked at aspects of this pancreatic regeneration, about how long could you be without VX770 or ivacaftor and still recover your pancreas. So this is an experiment where we took animals off for a 1 month period, then put them back on. Morphologically here, the gross anatomy of the pancreas, you see very well defined here. These cystic nodules showing the pancreas was getting pancreatic insufficient, going off, and then a recovery later in life. And again, if one looks at fecal elastase, one sees, a decline down to 0 in all animals, and a large proportion of them able to become pancreatic sufficient again. And if you sort of classify these into different groups, you see that the pancreatic insufficient group declines over time. There still are some that didn't recover, but there was this significant ability of the pancreas to regenerate itself. So now, the fact that we are now keeping animals on VX770 for life gave us also the opportunity to figure out, well, can male ferrets that are maintained on ivacaftor for life, are they fertile? Do they maintain fertility? And so this is an example where we bred homozygous males. Again, this was in this particular case, we allowed them to get their VX770 through the gill by nursing up to 3 weeks of life, and then they were fed orally. And the survival was no different from, and I'll show you the litter size was also no different. So these CF males can maintain fertility. And then we did the same thing with cystic fibrosis females that would go into heat later in life, maintained on VX770 for life. And indeed, they can get pregnant, and I'll show that there really is no difference in the size of the litters. But one thing that we noticed was the second parity, or the second time these gills were bred, it was very slow for these animals to come back into heat in order to breed a second time. Now, we looked at the amount of CFTR modulator, in this case, the ivacaftor that was in both the milk and the blood of the gill that were nursing these kits. And you can see there's significant more in the blood than in the milk, about 2 to 3-fold. And if one looks in the kits at the amount in their blood, one sees that it's also significantly lower than when they're fed directly. But nonetheless, this appears to be sufficient when the kids are nursing to keep them healthy. So probably the pharmacokinetic requirements for CFTR modulation early in life and in utero may be less than they are later in life, and especially around the time of weaning. This is just an example to show you what I commented on, the fact that the size of the litter of females that are maintained on ivacaftor or no ivacaftor, there's no difference. So there really is no impact of ivacaftor feeding on the size of the litter. And the same is true for males, either for CF males at homozygosity maintained on ivacaftor for life, or comparing to the wild type litter mates or wild type counterparts. Now, the one other sort of case study, we have to formally do this in more animals, but this was kind of a one-off experiment that I thought was fairly informative. We had been aging animals to develop Pseudomonas aeruginosa, which the CF ferret model does, develops this very purulent mucus and mucoid Pseudomonas with spontaneous mutations. This was an animal that I'm just showing the screen by bronchoscopy when the animal turned Pseudomonas positive. This was when it was harvested at the end and sacrificed. But this animal, between 17 months and 29 months of age, it had never been bred before. This male was bred and gave rise to 12 kits and 2 out of 7 matings, which suggests this animal was off ivacaftor for over a year and maintained its fertility and ability to mate, which... Now, the other thing that we had looked at about pathologies within G551D gills that are bred, I had mentioned that ones that come into estrus, we put back on VX770 and breed them. Their conception rates were no different than ones that were kept on VX770 for life. However, the litter size was significantly smaller, and there was a reason for this. There was a selection bias. The gills that were pancreatic insufficient and then put on ivacaftor, mated, and then had litters, that ones that had the largest litters succumbed to this fatty liver disease, which you can see here, there's cholestasis and bile accumulated in the biliary, in the bile ducts. And this correlated with liver damage, the size of the liver, and is equivalent to a disease that's seen infrequently in humans, called fatty liver or acute fatty liver in pregnancy, probably due to metabolic demand. And this also correlates with the size of the number of infants in the womb. And we did find a dietary solution for this, so we think this LPC, which we now give to all our pregnant CF gills, that was able to get past this pathology. So on my last slide, in utero, highly effective modulator therapy, treatment of CF ferrets and rats is effective. We hope that it's going to be useful in addressing more clinically relevant questions. And while the amount of this drug in the milk of the gills is lower than it is in the blood, it does seem to be effective. There might be something biologically important about that finding that enhances absorption of ivacaftor from mother's milk. I think an important message is, and I think this will bear out, as the field moves forward on these modulators, that they're not 100% effective. The pancreas is a really good indication of that. And even though fecal elastase may be in the normal range, there's likely turnover in the pancreas, and what that stress leads to later in life, it's unclear. And yep. So I'd like to thank those that played an important role in this. Yaoling Yi and Chinsen Soon really have driven this study with their team. Thank you.
Thank you, John. That was an amazing tour of the animal data. And next we have Dr. Jen Taylor-Cousar to take us into the world of humans. Jen Taylor-Cousar is a star and a pioneer in CF, and specifically CF and reproductive health. And this is really just a small snippet of her bio. She's a professor of adult and pediatric pulmonary medicine at National Jewish Health, where she co-directs the Adult Cystic Fibrosis Program and directs the CFTDN Center. She's been the PI on numerous CFTDN trials and is currently co-leading the Mayflowers pregnancy study of maternal and fetal outcomes in the era of modulators. She does a lot of other work. You'll have to read the full bio for more. Thanks, Dr. Jen Taylor-Cousar.
So thank you, Sylvia and Andrea, very much for putting on this session. I think it's really important, and I appreciate all of you being here, because the more people that know about this and understand this, then you can field these calls from the moms that you heard about who really need answers from us as CF docs. So these are my disclosures. The most relevant for this is that I have done a lot of clinical trial design work for Vertex, and I do most of the studies. So our learning objectives for the next 20 minutes or so are to identify the potential scenarios for in utero CFTR modulator exposure in the fetus, review safety of modulator use in healthy controls, define the potential maternal and fetal risks of modulator use in pregnant females, and then examine the available data from pregnant females with CF using CFTR modulators. So again, there are several different scenarios in which a fetus might be exposed to CFTR modulators. The most common one, of course, with the boom in pregnancies that we've seen since the approval of ETI, is the female with CF who has an obligate carrier fetus. We also have read case reports, I see Chris somewhere in the audience here, of the fetus with CF who has a mom with CF who's taking her drug for herself. But what we're here to talk about today really is the female CF carrier whose baby is diagnosed either by cell-free DNA or by meconium ileus present on the ultrasound. So I think it's important first to say, since we're going to be treating moms who don't have CF, do we have data in people who don't have CF who have taken modulators? And the answer is yes, because as we were developing the CFTR modulators, we did do healthy control phase 1 studies. So I'll show you a little bit of that data. So it's a busy slide, but it just summarizes by organ all the side effects that we're seeing. Unfortunately, in spite of the FDA repeatedly saying that women should be included in these phase 1 studies, there were not any women, so this is all males. But we do have 6 males and 17 in the varying dose VX445, which of course became elexacaftor. So you can see that the common side effects were those things that we've seen with Alex-Tez-Iva. So diarrhea, headache, a little bit of conjunctivitis, skin rash, things that were common. We did not see any serious adverse events, and there were no liver function test abnormalities in any of these healthy controls. So then we start thinking about pregnancy, and the risks are different if you're talking about treating the mom for her condition versus treating the fetus for the fetus's condition. So in the case of the female with CF, the thing that you're most worried about is stopping her modulator because of all of the case reports and case series suggesting that because these are quick onset, they're also quick offset, and the mom can become very sick by stopping her modulator. So we worry about the decline if she stops. We worry that she won't be able to gain enough weight or that she'll start to lose weight. And then we also worry about the risk to the fetus of the medicines that she's going to have to take to treat her exacerbations. On the other hand, with the fetus, we're worried about the relative unknowns in treating the baby with these modulators in utero. If we start to think about treating the fetus, then we have to think more about the mom, because again, the mom is healthy. She's a carrier, most of whom do not ever have symptoms. So we have to think about the pressure and willingness to use an unproven and therapy that's unapproved as well as unproven. We have to think about the side effects that you heard a little bit about. And we also have to think about the cost of the drug, because you heard that you can't always get it covered by insurance. And as you all know, this drug is incredibly expensive. But you also heard from John that there is a good reason why you might want to do this. And you heard it also from Lacey, and you heard it from Stephanie, because you can actually reverse or prevent some of the pathology that you see when the baby is never treated while they're in utero. So the first place that we go as we're developing new drugs is to look at animal reproductive toxicology to determine at what dose do we see toxicities when these drugs are given to rats and rabbits. So I'll show you another slide that looks like this. So just to orient you, on the left is the sexual and reproductive health impact. So chromosomal abnormalities in this case, and pregnancy and teratogenicity. Importantly, none of these modulators was tested in combination in these animal repro models. They were all tested individually. But essentially what we saw when this was done was that at normal human doses, no chromosomal abnormalities were seen and no pregnancy or teratogenicity were seen, because all those other doses that were used mean maximum recommended human dose. So 8 times, for example, the maximum recommended human dose led to toxicity. But at normal human doses, we didn't see toxicity with any of the individual modulators that were given. So the other thing that we really need to think about is pregnancy in general. So in the mom with CF, before we start talking about what happens when she takes modulators, we need to know what was happening with pregnancy in the past for moms with CF, because there are differences between moms with CF and healthy controls. So from 2 large databases, one in California and one national database, we know that there are increased complications in women with CF who become pregnant compared to females without CF. Those complications include more diabetes, more infection, more preterm labor, and more gestational hypertension and preeclampsia. There are also more complications for the infants that are born to mothers with CF. So increased rates of congenital anomalies, particularly cardiac anomalies, increased rates of jaundice, more likely to undergo C-section, and more premature births. Recently, Ashcroft and colleagues in the UK used an obstetrics database and showed that lung function and gestational age and weight were correlated. In other words, the lower a woman's lung function, the more likely it was that she was going to have a low birth weight, early term baby. But you already heard, again, from John, that these do cross the placenta. So this is work that Erin Trimble and colleagues did. The concentration is on the y-axis. The different drugs are on the x-axis. And you can see that in maternal blood, cord blood, and infant blood, when the baby is getting exposed, those levels are the same as what mom's seeing. So they are definitely getting a full dose when they're in utero. So up to now, all of the studies that we have in pregnancy before the modulator era and some in the modulator era were retrospective, often single center, sometimes registry studies, but we've never had a prospective multi-center study. So that is what we've been doing for the last few years. It completed enrollment in December 2024, and we're expecting to put the first manuscript out next year. But what we've done in the study is enrolled 315 women with CF who are enrolled at various parts of their pregnancy, and then follow them and their infants through 2 years postpartum. And I'll just show you a little bit of data from the interim data cuts. So probably because of all of the previous retrospective data suggesting that these drugs were probably safe in pregnancy, about 87% of people chose to stay on their modulator for the entirety of their pregnancy. So different from starting this second or third trimester, these fetuses are exposed from the time of conception. About 83% of those who stayed on modulators were on Alex/Taziva. When you look at delivery outcomes, and this is as of September, so 280 live births, we're still seeing a fair amount of prematurity, not higher than it was in the past, but my suspicion is that the reason for this is that in the past, we asked moms whose lung function was less than 60% to avoid pregnancy. Now we have people who have lung function as low as 28% on Alex/Taziva having babies that are in the Mayflower study. So I think that we're seeing more, or the same number of premature babies because we have sicker people who are having babies. When you look at the infant complications, the first 6 weeks after delivery, there's nothing that really stands out from what we were seeing in the past in the pre-modulator era. Certainly no more congenital anomalies than in the past, and again, the preterm births are similar. One of the things that's come up a lot because of adults and some kids who have had mental health side effects on ETI is whether or not it's going to affect the infant's mental health and their milestones. So the CDC used to say that by the 24-month point, we wanted to see kids at 50% of kids getting their milestones. Now, because they're trying really hard to pick up neurodivergency earlier, they say they want 75% of kids to reach their milestones at each one of these markers. And you can see that for the time points that we have, and of course it gets lower there are lower numbers at the end because all the babies are still growing up. But for the most part, we are seeing that babies are reaching their developmental milestones at the rate as expected by the CDC. So what are the current approvals? You heard a little bit about this earlier. So right now, we have approval in the US down to 1 month for IVA, down to 1 year for LUM-IVA, and down to 2 years for ETI. Of course, the newest drug, Alyftrek, is only down to 6. So that begs the question, what happens? As you heard from John, there are some risks to stopping the modulator, at least in the ferret model, and we have seen that in a couple of human case reports as well. So I wanted to talk a little bit more about breastfeeding. So again, you saw in the ferret model, we saw in the reprotox models that lactation does lead to exposure of the baby to the different modulators. There's also, especially those of you who are pediatricians will know, a black box warning on ivacaftor or any drug that contains ivacaftor, which of course is all of them, that there were baby rats who were directly dosed with ivacaftor who developed cataracts. So again, this is the baby rat model. This is not CF rats. This is the rat model that's used during reprotox. The other issue that you will see if you read the fine print in the USPI is that when baby rats were directly dosed with tezacaftor at about 2 times the maximum recommended human dose, they developed seizures and some developed death. Again, that's in the fine print. Anybody can find it in the USPI. But you saw John's ferrets. John's ferrets are not having seizures and dying from being exposed in utero. He also graciously let me take some ferrets that were already deceased and work with my pathologist to look at their eyes, and none of them had cataracts in spite of being exposed in utero and post-utero. Also, Elena Fushik in Brisbane has actually looked at CF rat models and showed again that they had greater lens thickness, but none of them had cataracts and none of them have had seizures or any brain development issues that has been observed so far in all of her experiments. So when we're thinking about breastfeeding, again, when you look at mom and baby and look at their plasma concentrations, they're actually very similar in utero. But as you saw with John's model, the breast milk concentrations are much, much lower. And if you think about it, as the baby grows, the effective dose is going to get smaller and smaller as the baby's weight goes up. And so that's sort of what you were seeing again from Aaron Trimble's data. We actually retrospectively did ask providers who were taking care of moms who stayed on during pregnancy and or breastfed afterwards. And so in total, 69 infants were breastfed while their mom was on CFTR modulators. None of them had cataracts, although only 6 of them actually had formal assessments. None of them had modulator-related LFT abnormalities. And then subsequently, Raksha Jain and Michal Steinberg from Israel did serial cataract examinations on 23 females whose babies were exposed in utero and via breastfeeding. And of those 23, 3 had very small, clinically insignificant cataracts. In other words, wouldn't have been picked up if they hadn't been looking for them. So whether that's true, and unrelated, we don't know because we have never actually looked at the eyes of babies who weren't exposed to modulators who were infants of moms with CF. But what we realized at this point, after looking through all this data, because we did have a workshop that was sponsored by the foundation last November, where John presented and others, and we went through all of this data for about 8 hours, we realized that there were some serious knowledge gaps to recommending this therapy for everybody. So we don't know whether the brain accumulation that's been observed in some of the rat models is relevant for humans. We don't really know enough yet about the pharmacokinetics of CFTR modulator use in pregnancy, and that's currently under study in the Mayflower study. There are actually 2 posters from Chuck Esther's lab, one on mom's pharmacokinetics and one on baby kinetics from the Mayflower study, so I encourage you to go see those. We also don't know what the critical time point is for initiating CFTR modulators during pregnancy to effectively prevent complications. Again, obviously, John's doing it in the ferrets at E28, 3rd trimester. Well, people and ferrets aren't the same, obviously, in every aspect of their physiology. And so we need to figure out, where do you need to start this? Because it may be that it's too late to save the VAS if you start in the 3rd trimester for people. And it may be that your pancreas isn't going to function as well if you wait until then versus the moms with CF who were taking it and the baby was exposed from conception. You'll see a little bit of that in Sylvia's data. We also don't know what the minimal effective dose is. Like, should we be dosing the mom at a lower dose instead of the high dose since they're seeing that full dose and obviously the baby weighs a lot less? And we don't know, because there isn't yet data that's published, about the safety of administration of ETI to kids and infants under 2 years of age. So again, because the foundation is very gracious in their funding of really important questions, they are planning to fund the PROTECT prospective observational study. It's going to be a 2-part study in which we'll follow people throughout their pregnancy once they start taking the modulator, or those who can't access it. And this is moms who are CF carriers. And we'll also follow them after pregnancy, especially if they're breastfeeding or direct dosing their infant. Our goal is really to figure out whether or not this is safe and whether it's effective in, 1, preventing meconium ileus surgery, or at least preventing them from needing to go to the NICU. And will it prevent other things like pancreatic insufficiency and congenital bilateral absence of the VAS? Will their growth be better, and will moms and babies tolerate it? Again, we'll also be following them out through breastfeeding and through 2 years of life, as we're doing in Mayflower. So we'll look at the safety and efficacy of either getting it through breastfeeding or direct dosing. This, again, will all be observational, and so it will be the choice of the mom and the dad and the doctor who is taking care of them. We're just going to collect all the data so that we can share it with all of you. So with that, I will stop and thank everybody who came to the international workshop, because that feedback was essential for us to move forward with designing this study. And I think we're stopping for questions.
I'm next.
Oh, yeah, you're right.
All right. Good afternoon. Thank you all for hanging with us. And now it is my distinct pleasure to give you an overview of existing data that we have on prenatal ETI exposure in both the US and a select handful of European countries. All of my opinions are my own. I have some research relationships that do not steer this data one way or the other. So objectives for my review will be the current collective experience with prenatal ETI use, both in the United States and across a handful of European countries, reviewing the timing of ETI initiation in both of those locations and the relationship to prenatal ultrasound findings, reviewing delivery and newborn outcomes, reviewing existing infant monitoring data for what's available after birth, and of course, implications for future use. So in total, we have complete data on 20 infants spanning pregnancies between 2021 and 2025. 4 of the submissions to our registry included mothers with CF who had infants with the genotypes listed on the right, and 16 carrier mothers with the infants having genotypes listed on the right, with the majority across both of those 2 groups being Delta F508 homozygous. In the European cases, there was 1 CF mother and 10 carrier mothers. 5 of the infants in the carrier mother group were Delta F508 homozygous, and both the twins to the CF mother were Delta F508 homozygous. In regards to diagnosis, there were 3 families in the US group that had prior children with cystic fibrosis, prompting perhaps some investigation during the pregnancy. 4 in the European cases. 3/4 of the US cases had a genetic diagnosis through amniocentesis, with a slightly higher proportion undergoing amniocentesis across the European group, with a mean gestational age of diagnosis at roughly 20 weeks in the US, and 60% of those infants being F508del homozygous, and a slightly higher proportion being male sex of those who responded to that question. And similar proportion of F508del homozygous infants in the European group. In the US, All families had insurance, although this did not explicitly guarantee coverage of ETI. 50% had any prior children, with or without CF. Mean maternal age was approximately 31 years. And the majority of families reported Caucasian race, with one reporting Asian Indian race and another reporting African American race. In the European patients, there were 83% accessing ETI through the public health system, one receiving ETI through a private health company, and one through a private donation. And the cases were accumulated from 5 countries, most from Spain, 2 each from Italy, Germany, and Switzerland, and 2 each from Italy, Germany, and Sweden, and 1 from Switzerland. 80% of the U.S. infants had some abnormal prenatal ultrasound, with the vast majority having suggestion of meconium ileus, either with dilated or echogenic bowel, or a frank diagnosis of meconium ileus. 1 also had polyhydramnios, and 1 had growth restriction and ventriculomegaly, although this is ultimately attributed to a separate non-CF diagnosis. Among the European cases, 3/4 had abnormal prenatal ultrasounds, all suggesting meconium ileus. In the U.S., these ultrasound findings spanned anywhere from 18 to 33 weeks gestation and 16 to 29 weeks gestation among the European cases. When we look at the U.S. prenatal ultrasound results as a cumulative list, there is a majority of patients who had success in resolution of the meconium ileus that was identified with either resolution or non-surgical interventions at birth. But there were some that did have persistence of findings. And we see that initial abnormalities on ultrasound ranged from that 18 to 33 weeks. ETI initiation in 1 case began pre-pregnancy for a maternal CF diagnosis, and as late as 35 weeks. An outcome resolution typically was noted anywhere from 27 weeks at the earliest in imaging findings to more 35 weeks with ultrasounds or at delivery when there was no meconium ileus present. When we take just the infants who had resolution of finding, they had a mean initial ultrasound abnormality at roughly 25 weeks. ETI initiation, really quite a brief time period after that, only just shy of 27 weeks, so about 2 weeks in between, and outcomes resolved in those infants at a mean of 34 and 27 weeks gestation. When we look at the infants who did not have resolution, sort of two groups seem to present themselves. One that started at 25 or 26 weeks, and one that started at 34 to 35 weeks. So across an average of those two, they started ETI at 30 weeks with a similar mean time of ultrasound abnormality around 23 weeks and an exposure time of just under 9 weeks prior to delivery and persistence being identified of meconium ileus. In Europe, it was a similar spread, so between 16 and 29 weeks for the initial ultrasound findings, ETI initiation that was a mean of just under 31 weeks, treatment duration somewhat more brief in comparison to the US cases at just under 7 weeks, and 3 infants that had persistence of meconium ileus at birth, 1 requiring an ileostomy and 2 requiring ileostomy and 1 requiring just medical intervention. So if we look at this all together, US cases had overall time to abnormality finding at around 23 weeks gestation, with ETI initiation around 25 weeks, irregardless of whether there was an ultrasound abnormality or not. Follow-up ultrasounds among those that had resolution occurred about 9 weeks after drug initiation. Most had resolution of findings within about 7 weeks of treatment. Among those that had unresolved meconium ileus that was non-surgical, their treatment duration was only 6 weeks, in contrast to 1 unresolved case that had perforation with a total treatment time of 16 weeks. Across all infants, total treatment prior to birth averaged 11 weeks. In the European cases, initial ultrasound findings were somewhat earlier, about 20 weeks, but there was a larger time interval between abnormality identification and ETI initiation, so about 10, not quite 11 weeks on average. 6 of the 9 infants that had meconium ileus findings had resolution of those, with a mean of 8 weeks before identifying that on ultrasound. 1 had unresolved non-surgical MI, and they were treated with 5 weeks of drug at a half dose. 2 had unresolved surgical interventions, and their treatment duration was quite a bit shorter, only 3 weeks. And in total, across all infants in the European group, they had a mean ETI treatment of 6 weeks and 4 days. So what's interesting to examine is how newborn screen results evolved for each of these groups. In the US, infants all had newborn screening completed, was reported for most, but not all. The mean IRT was approximately 85 nanograms per milliliter, which would flag in the vast majority, if not all states, ranging from just under 36 to 201, with 35% of those having reported newborn screen data having a negative newborn screen, with the genotypes listed below. Newborn screening data was available in only 7 of the European infants, and they had a similar mean immunoreactive trypsinogen and a range that started slightly higher, but capped out at around 200. So similar range overall. When we look at that together with sweat chloride, I think the results become a little bit more interesting. So the mean sweat chloride in the US group was just under 60, and it ranged from 23 to 115. 4 of the 17 with data available had a negative sweat chloride under 30. 5 had an intermediate range between 30 and 60, and 52% had a result under 60 millimoles per liter. And I've organized this such that you have newborn screen result, IRT, genotype, and sweat chloride. And what I find interesting is that there are some infants that had clearly negative results all the way across the board, but some that had a negative newborn screen, but actually a positive sweat chloride. So certainly more to be learned from the group. When we look at European sweat chloride data, their mean sweat chloride was slightly higher, 83 millimoles per liter, with a range between 40 and 105, and only 1 infant having a sweat chloride returning under 60 millimoles per liter. Another data piece that was available in most but not all U.S. infants is fecal elastase data. So we have 18 prenatal exposures who reported fecal elastase after birth. 14 of those 18 had ongoing exposure to ETI through breast milk. The mean fecal elastase in that group was in the pancreatic sufficient range at 235 micrograms per gram, and 43%, or 6 of those 14 infants, maintained pancreatic sufficiency on all metrics that were collected. 2 of those trended towards pancreatic sufficiency, so their fecal elastase was somewhere between 100 and 200 and rising when reported, and 6 of the 14 were pancreatic insufficient and receiving pancreatic enzyme replacement therapy. Of those 4 who had ETI exposure stopped at birth, did not receive any through breast milk, their mean fecal elastase was 77, and all were pancreatic insufficient. Across the European infants, a bit of a different story, and part of this, I wonder, may relate to the timing of ETI exposure during pregnancy or perhaps other factors. Initially, 50% of the infants had a normal fecal elastase above the 200 microgram per gram range, but all ultimately shifted to pancreatic insufficient status in spite of some having breast milk exposure with maternal ETI ongoing. So all ended up on pancreatic enzyme replacement therapy, and as far as I know, all remain pancreatic insufficient in the absence of addition of other CFTR modulator therapy later in childhood. In regards to lab monitoring for safety, no major red flags across either group. All infants had additional monitoring reported. Discrete data was reported in 14 of those infants with things like transaminases, bilirubin, GGT, alk-phos measured. In some cases, lipase and amylase were also measured. And in general, results were within normal range or only slightly outside of normal range if reported as abnormal at all. I'll call your attention to a couple of more unique cases with one single report of a high lipase peak during a period of breastfeeding with ongoing ETI exposure in one infant, and a report of unconjugated hyperbilirubinemia leading to maternal drug discontinuation after birth. There was also a report of a concomitant genetic diagnosis of Wittevin-Koch syndrome, and that was in the infant who had the widened ventricles and non-meconium ileus ultrasound abnormalities. In the European cases, there was one case of mild hyperbilirubinemia, 2 cases of mild transaminase elevation, and one infant who was reported as having some hypotonia, still persistent, approaching 1 year of age, and widened cerebral ventricles, as well as one report of gallstones. In regards to adverse events, among the mothers, some reported flu-like symptoms for a maximum of 2 weeks, post-delivery abdominal pain. There was one report of possible worsening of depression and PTSD related to prior birth events. And there was one report of premature rupture of membranes. There were no adverse events reported in the infants. And in the European cases, 2 mothers reported rash, and in one case, dosing was halved, 1 mild transaminase elevation, and 1 report of headache. There were, however, 2 episodes of what was concerning for possible withdrawal syndrome, with 2 infants requiring hospitalization for respiratory exacerbations, 1 briefly after stopping ETI at age 5 months, and 1 at 2 weeks of life who was not able to have any breast milk exposure. And then, big question that has many wondering about outcomes is vas deferens investigations. So most submissions to our registry ask about vas deferens, but have no data collected at this time. There was one case in Sweden that had a report of identified vas deferens that was normal in appearance, but no information from the remaining cases either in the Europe or the Europe group or US group. And then another big question is what happens to these infants after delivery? So many have sought or considered transition to direct dosing of CFTR modulators. 40% or 8 of the infants in the US group are reported as having transitioned to an oral CFTR modulator therapy, anywhere from 1.5 to 6 months, on average about 4 months. 2 are prescribed label-approved dosing, Lumiva as an example. 1 is receiving maternal ETI, and 7 are receiving early access ETI. Among the European group, 6 have transitioned to oral CFTR modulator therapy, anywhere from age 12 days to 2 years. 2 have label-approved Lumiva. 1 has early access Lumiva. 2 have early access ETI, and 2 have label-approved ETI. So what can we take from this data and how it has evolved over the past few years? We know that more and more pregnancies are being treated before birth. Fetuses are being treated before birth with CFTR modulator therapy in a variety of settings, many with hallmarks like meconium ileus being a driver for that drug initiation. And we know that prevention of disease hallmarks characteristic of CF, like pancreatic insufficiency, meconium ileus, male infertility, that these are positively affected in at least some cases. Some of these outcomes are more challenging to evaluate in particular male fertility, but I think there's much more to be studied in the coming years as these infants age and evaluation becomes more accessible. I think there's also a strong level of implications for how these affect newborn screening and how families will need updated counseling about what they can expect in the newborn period, and also the timing of dose initiation, the dose that's used, the duration. All of these can yield disparate outcomes, as we've seen in the cases that have been shared. This all leads to a greater question of education, access, resources, and equity. And so I'm delighted that there will be broader study coming, and hopefully we'll have more exciting data to share with you in coming years. And I think with that, we'll invite all of our panelists up back to the stage to speak and answer questions.
If anyone in the audience has questions, we invite you to come up to the mic and go right ahead. Thank you all so much to our speakers.
Hi there, Brooke Moore, Children's Minnesota. We have 2 moms that we've treated so far prenatally. And I'm just really curious about how you get early access approved, because we've gotten it approved for the moms, no problem, but babies is another story. So
I can comment on that. So we have had relatively good success in getting early access Trikafta, and I think full transparency, some of it likely is insurance related. I think some insurance companies put up more red tape than others, and I have to give absolute major props to our specialty pharmacy team and our whole multidisciplinary team in putting efforts behind getting access for these infants that are exposed before birth. So I think in some ways it's probably case dependent based on the insurance, but we've certainly compiled some language and letters and resources that have been helpful in some situations to get authorizations ultimately approved. And I think as the PROTECT trial moves forward, our goal is to have resources available for everyone to use as we make them more and more refined and be available for all.
Yeah, ultimately, Sylvia's not giving herself enough credit. So out of the workshop, there were 2 different working groups. So one was a study design group, and I'm leading it, and then Sylvia is leading the resources group. And so they've worked really hard. It's an international group of folks to create these documents, patient-facing and provider-facing, that are going to soon be up on the CF Foundation website.
I do have a QR code for one of those resources that I can put up for everyone.
Can I add one more thing on that same topic? So in these clinical trials where you're following all these kids, some couldn't get access, some could. Is there a way to engage, like pick one of the insurance companies that, what's the cost savings for those that, win on early, and then they could win over all of them at once with that?
No, it's a great question, John. And one of the sub-studies or ancillary studies that was suggested by the International Workshop Group was to have a cost analysis subgroup to look at that question and then use that data.
Great.
Hi, Liz Bergener from Children's Hospital Los Angeles. One of the cases I'm really curious about is the F508del with the 12TG5T, because that's not necessarily a disease-causing mutation, although it looks like that was maybe in a mom that had CF. But have you thought about what are you guys thinking about in the trial as far as what are you going to do with VCCs? What are you going to, like with moms that are carrying mutations that aren't necessarily going to cause CF, and how you've thought about dealing with that?
That's a great question. For the trial itself, those folks will be captured in the registry. Right now, Mike Zaretsky from Children's Hospital Colorado has a registry, and Sylvia does as well, and they're working on merging those. But we are only going to include those with known CF-causing variants, because we've got a very specific question that needs an N, be appropriately powered. So we're not going to include VCCs in the trial, but those folks can go in the registry.
Yeah, it'll be interesting. I've had 2 with signs of meconium ileus that have VCCs, and it's tough to know what to do with them.
Hi, my name is Jessica Farrell from Houston Baylor. I'm an adult provider. My question is, in y'all's experience so far with getting carrier moms prescribed ETI, has that come from maternal and fetal medicine providers, pediatric pulmonologists, adult pulmonologists? Like, where have you guys seen that work, or is it kind of across the board depending on the center?
It's varied quite a bit in terms of the families that I've spoken with. I would say in general, it tends to come more from the CF center providers, sometimes pediatric, sometimes adult. At our center, typically it's the adult CF team that prescribes it, but I will meet the families when that discussion is going on, just to get to know them in general, regardless of what they decide. But I've heard of families where prescriptions have come from GP or a non-CF provider. So I think it varies, but in my experience, it's been primarily through someone at the CF center.
Yeah, and that's one of the things that we're hoping, again, and we've worked with a lot of maternal fetal medicine docs on this project because we want them to publish this in their journals and get the word out.
Right.
Because it really needs to be working together. Like the adult CF doc, sometimes the peds doc, eventually for sure the peds doc, because they're going to be in the registry at the CF center, the babies are. So it really should be everyone involved. But the prescriptions often, as Sylvia said, come from the adult providers.
Yeah, I think another big point of importance with this is going to be educating the MFM teams on
Absolutely
what is available. So that's a great point. Thank you.
Hi, Deanna Green, Johns Hopkins All Children's Hospital. Shameless plug, there's a thematic poster session from us, 419. We've submitted most of these cases as well, not all of them by any means. I have two questions and an answer. Number one, we are the providers as the pediatric pulmonologist, providing this to our parents. We were not able to establish with any MFMs or any adult CF providers that would be willing. So I took on the prescribing to the mom. And then my question is truly if anyone can give some more guidance towards cell-free DNA. We are having a lot of difficulty with that, and especially in the state of Florida, in which abortion is really not an option. And there's a certain risk with doing amniocentesis later on in life. So we are dealing with the variance on the cell-free DNA, anywhere from 2 out of 10, 9 out of 10, getting lots of different parts of that. And if anyone could comment what you've heard from your MFMs. Right now, we have elected not to give it to those patients without having definitive diagnosis. So a little bit more information would be helpful.
Yeah, it's a great question. And so for those of you who aren't familiar, cell-free DNA can be done from the mom's blood at 10 to 12 weeks approximately, but it's a screening test. It's not a diagnostic test. So in the PROTECT prospective study, we will allow that to be the test if both parents also get their genetic testing done. If you talk to the MFMs, the risk of CVS, if it's done properly, is actually pretty low. And so most people have been insisting on that being done before they would actually treat.
Yes, that's generally been the party line in the OB and MFM folks that I've spoken to, and in general, in the absence of some very convincing ultrasound findings or other data to help inform the fetal diagnosis, that seems to be the recommendation.
Because you do need the genotype to decide whether you're going to treat or not. So whether that's from each parent or from the baby themselves, like you have to have that to, I mean, if they both have stop mutations, obviously it's probably not useful.
Hi, I'm Mel Collins from ComplicaTions. I'm a pediatric pulmonologist and a mother of a very 16-year-old opinionated daughter about women's health and bodies, which probably colors my question today. But as moms, you have so many burdens on you. I really appreciated your talk. I thought that was very inspiring. But it is like your body, not just a vector for carrying a baby. What kind of monitoring or consistency do we have for mothers who are taking ETI therapy who do not have cystic fibrosis, so carrier moms?
So you can speak to your experience. I'll say in the PROTECT study, we are going to be doing anxiety and depression screening throughout the study.
In my experience, the testing was done at the same rate as my infant So at that time, it was 3 months. Now it's down to 1 month. So we tested every 3 months for my, liver values. And then, of course, the cataracts prior for me and then also for him. And yeah, it was pretty cut and dry. Like, hey, let's just follow this protocol over here that we already have.
But yeah, I mean, I take your point very seriously. And we actually did have ethicists who were part of our workshop and will be part of our study design day team. Because that's one of the things I was showing in the one graph is that there is pressure. I mean, I think that if I were the mom, I'd want to do it, but there's a lot of pressure for the mom. And we want to make sure that people aren't putting external pressure on her to take it if she doesn't want to. And that's why we're still going to include people in the trial, even if they can't access it or don't want to take it if they're willing to be in.
Nigat Mehdi from University of Oklahoma. I really appreciate this session a lot. I was just wanting to comment and ask others in the room too. Are we having difficulty trying to make sure that OBGYN offers this to every mother, regardless if she's a Caucasian, Hispanic, Native American? Because I do have those mothers in my state too. And I find that it is very late in the process that I am involved or we are notified that we have a CF baby coming or something. So I think CF Foundation should push for this for the OBGYN. They all need to screen every mother. I think we are losing the opportunity to treat babies because we don't know. By the time pulmonologists get involved, they are pretty close to delivering the baby. And then I don't know if it will be that helpful, when we come to know about it. So I would really push for that because we are trying to do on our own in our state too. But I think this should be everywhere, more awareness by them to screen. A push for them to screen mandatory, to improve the outcomes.
Yeah, no, it's a great point and why we've been trying to work so closely with a number of MFMs on this project. We actually just published in the Green Journal, a group of us, pregnancy and cystic fibrosis, and mentioned this as part of that discussion. And then we have published the workshop report in JCF, but two of the MFMs who were involved with the workshop are going to write a letter to the editor of the Green Journal so that draws attention to that. We have a lot of education to do. And Sylvia is going to be presenting at one of their conferences as well. So we're working on it.
Thank you.
Hi, I'm Silvia Cardenas. I'm a pediatric pulmonologist in Cleveland Clinic Children's. And this is not so much a question, but I would like to hear your experiences in clinical practice as far as how you're navigating the questions with families when they come and they are undecided about doing an amniocentesis, knowing that both parents are carriers, and they are putting the weight on making that decision on the fact of whether there is approved medication, FDA approved, to initiate treatment. So that's a way that the families have on, if there is a drug that I could use, then I will opt for an amnio versus if there is nothing that I can use that is confirmed that I will be successful, then should I use it or not? How are you navigating that in practice?
Do you want to go first? You want me to? So, I think it's a great question. Obviously, there are lots of drugs that we use both in kids and in pregnancy that are not FDA approved all the time. And I think it would be a lot easier to use this one if it didn't cost $320,000 a year. But one of the things I would point to is that we have been able to successfully get this drug, even though it's not on label. There's a question of whether the study and the Mayflower study will help get pregnancy on the label. And we will push for that for sure. But I would just remind people that we use, I'm med-ped, so we use drugs in kids all the time that aren't specifically approved. And so if you can get access, that's still a possibility.
Hi, Ariel Berlinski, Little Rock, Arkansas. I'm curious about what the management of pancreatic insufficiency has been in the newborns. But I just met a family 3 days ago, this week, before coming, and we were discussing about, we were going to start enzymes, but when are we going to, at some point, say, are you pancreatic sufficient or not? And if you are breastfeeding, is this going to be enough? Because looking at your data, there's a lot of variation of the outcomes. Some will continue if you look at Europe, they will all go to be pancreatic insufficient. So what will be the downside of keeping them on enzymes? And then at least for the first couple of years when the growth is such an important thing, and that's kind of the big goal of starting them early on therapies.
It's a great question. I have a recent case that I've not yet been able to add to the registry that maybe can speak to this a little bit. There was a family that came to us from another center. Mom herself had CF, started ETI after becoming pregnant to treat the fetus in the setting of echogenic bowel, if I'm remembering correctly. That resolved. Baby has done great. After delivery, there wasn't much of a discussion of what was going to happen with pancreatic enzyme replacement therapy, whether that would be started based on the baby's genotype. And so they followed fecal elastases diligently. They became pancreatic insufficient and then started at that time. The family came to us and we were able to get early access, which the center they were being cared for and did not feel comfortable doing. And within 2 weeks, the baby regained pancreatic sufficiency. So I think it's a bit of a moving target because as the data showed, as you mentioned, there's quite a disparate outcome, which in my opinion, just sort of looking at it with a bird's eye view several times is probably related to the timing of when it started. So if it's 26, 27, 28 weeks, I think more of those babies have ended up being pancreatic sufficient versus those who started on average 30 weeks or later. I think less of those have ended up being pancreatic sufficient at birth. But there's not harm in starting pancreatic enzyme replacement therapy. So I think you could probably go either way. That's my opinion. You have a different one.
No, I totally agree. And actually, I was going to turn that to John and say, have you considered doing or giving the ivacaftor or Orkambi or ETI when you can get it to the ferrets, the pregnant ferrets from day one, so we can see what the comparison is between moms with CF who take it and start it, from conception versus the ones that are starting it later.
Yeah, it's a really good idea. This came out of that Protect workshop, and we've actually started a study on that. Where we have the animals that I would show that we would keep on ivacaftor all the time. We put them on enzymes with the thinking that you're relieving stress off the pancreas during these, but we're now doing a cohort where we take them off enzymes to figure out, does it really make a difference in end result when that animal's an adult? Like, are more falling into that pink group that stayed pancreatic insufficient regardless of the fact that they stayed on modulators their entire life? So, yeah, it's a good study.
So I'm just going to throw this out there because I've dealt with this, at least 2 of my 4 patients, but I really want to hear this from Lacey because I think you actually already eloquently talked about it when you introduced your son and how much can be related. We as physicians think of the pancreatic enzymes as being very helpful, but it can be very anxiety causing to get your child to keep using them. And if you're going back and forth, deciding on whether or not they need to use them. So I think having a parent perspective on this might help us too.
I think so. While I was breastfeeding and taking ETIs, we kept him on the enzymes. I felt really comfortable with that. My care team felt comfortable. We had talked about it. We were also with a GI at that point, and that's kind of what he recommended as well. And then when we tested the fecal elastase again, and it had elevated so much, we were comfortable with taking him off and kind of seeing how it went, monitoring closely. I'm in very close contact with my care team. And so we kind of all felt comfortable with that. And I continue to feel comfortable. I think under the guidance of the CF team and my GI, we test about every 3 to 6 months. So, we're just going to keep an eye out. I'm not delusional. I realize that there's a possibility that he will have to go back on. and we will deal with that when we get there.
Hello, my name's Mia Ratkowitz. I'm a pediatric pulmonologist from Phoenix, and thank you for this amazing session. Very well timed with some NIPT testing that just returned on someone I did a prenatal consult on who carries a Delta F508, and then a second very uncommon mutation that is in the 3 of 4 instances described in CFTR is associated with pancreatic sufficiency. The mom has no findings of meconium ileus on ultrasound, but she's very, very motivated to start Trikafta. And so I'm still a bit on the fence. If she had any findings suggestive of meconium ileus, I would be 100% on board, but would love your thoughts or input on someone who probably, or is most likely going to be pancreatic sufficient.
Well, one of the things that we're doing in addition to the pancreatic testing is looking at cultures. I mean, obviously we can't do lung function. We don't try to squeeze babies while they're asleep anymore with the PFTs. But we are going to try to figure this out over time in these babies who are exposed. So I suspect that it's not just the pancreas and the vas that you are going to be affecting. So if it were my kid, I'd still want to do it. But that's, purely my opinion.
Okay. Thank you.
Hi, I'm Nicola Robinson. I'm an adult CF physician from the UK. We have this exact problem at the minute, and well, not problem, exciting opportunity at the minute. I have a couple of comments. So you've presented the US and the European data. The Europeans are obviously quite far behind. We're at least 4 weeks late getting this drug to our patients. The sooner we can do this kind of above board, the better. And we have had questions and queries from certain people, and we've knowledge that drug is being bought online, and parents.
There's a black market.
Yeah, I was going to say that there's a black market for this. And do you have a lot of experience of people buying this and then trying to do it themselves? Because that's my biggest concern, is that moms are doing this themselves. They're not getting any kind of looking after or monitoring throughout this.
I have heard stories primarily from other mothers, and I don't know, Lacey, if you have any comments on it, about ways to access ETI through non-medical routes happening not infrequently, as you described. I've not had anyone come to me after the fact. I've had people come to me asking, can you help me? And of course, we do our best in those situations. But I think in general, my standpoint would be, regardless of how someone is getting it, if they could at least have appropriate health supervision, that would at least make it one layer safer, in my own personal opinion. But I have not had a personal experience with it.
Yeah, and I will briefly tell the story of a woman who is ex-US who could not get access in her country. And so she contacted me to help her. And she was going to go so far as to try to go to Argentina and get Trixacar after me getting her in touch with Marco. Eventually she came to the United States for a visit and got in touch with the mom's Facebook group and got 20 weeks of Trikafta that fell off trucks and took it back with her to Germany. So what I did was contact my colleagues in Germany and say, can you please help follow her? So she did get it in a way that's people are going to do when they're desperate, but she is being followed, because I think that's our job to figure out how to help people find somebody in their area that will follow them, even if it's not their CF center, if it's another CF center who's willing to do it.
Especially when the obstetricians and fetal medicine aren't quite up to speed yet. Right. I think that's our job.
Right.
Yes.
Karen Miller, Boise Adult Center Director. Thanks for a fantastic session. Really appreciate it. As you may know, Idaho has one of the most, if not the most, restrictive abortion laws in the country, with no exceptions for anything whatsoever. And we have had pregnant mothers become septic and been near death before they were able to receive care, sitting in the parking lot of the hospital for hours, of our very hospital. We have lost 35% of our state's obstetrician gynecologists, which make it very difficult to get patients in to see, especially the high-risk MFM folks. And I have had a CF patient need 5 to 6 months to be scheduled for her first visit. So I think the slide showing the European delayed care for ETI is extremely important for us in places like Idaho, where I fear that amniocentesis will not be performed in a timely fashion and data will not be available on the fetus's status in any kind of appropriate way to dose in a timely way.
That's a really, really important story to share. And I worry about how that may be changing in many states in our current landscape. I will say I have had a ray of hope from discussions not really specific to this topic, but more related to newborn screening, highlighting the flexibility and availability of genetic counseling as a resource. And so I wonder if there might be some way to access non-OB-GYN MFM resources, or I don't know if there's like some telemedicine option for maternal fetal medicine care that perhaps could be accessed. But I wonder if there could be some alternate routes to help diagnosis and help decision making. But
I believe there's a 6-month wait to get into our genetic counselor. 2 years if you're an adult.
So I'm going to follow up on the newborn. And so there are 2 questions. So the first one is about salt supplementation and vitamins. So what are you commenting? Because at least if you're correcting the defect, do you still need it? And is there any harm in actually continuing? And I have my own idea. And the other thing is about the timing for starting enzymes. Because typically we would diagnose somebody with CF maybe by age 10 to 14 days, and they have pancreatic insufficiency those time they're not receiving enzymes and they do well. So how do you manage that with the newborn? Do they latch into the breast and get their first enzyme? This is an actual question, and I'm really paraphrasing some of my conversations, and at least my reasoning was, well, so even in patients who are born to mothers with CF, we probably don't see them before they have 5 days of life. And if they have medicine on board, I don't think that's a problem. And even if they don't have medicine on board and you just have CF, we see you for 2 weeks, and that's not a problem. But it's creating also an anxiety on the parents or the prospective parents as to, well, do we have to act just after the child is delivered, or is there? And I don't think there's any guidance, but also I would like your comments because you are kind of on the receiving end on that question.
Sure. So I think in regards to the salt and vitamin supplementation, we typically, our practice has been to recommend those irrespective of whether there's been ETI exposure before birth or not, and irrespective of whether there's ongoing ETI exposure or a weaning plan or how that's being addressed after delivery. And I'm a data-driven person, so I like to see their sweat chlorides. I like to see their first set of annual labs, which includes electrolytes and some of the vitamins. So we usually do some form of shared decision-making based on, as those results trickle back, how to inform scaling up or scaling down, typical medical treatments that would be recommended for an infant with CF. And then in the regards to pancreatic enzyme replacement therapy, so in one of our cases, we had a mother who had a prior child with CF, had a second child with CF. The second child was in utero exposed, and they felt very comfortable just going ahead and starting enzymes at birth and just hoping for some improvement as we gather data with fecal elastase. So that's one of the cases of a family that was quite comfortable with starting a therapy that they were used to from their older child. But I can also see that there might be some families that want to watch and wait and get more data before starting a therapy. So I think it's somewhat individualized.
And I was just going to add that this is part of that reason I was saying earlier that there needs to be a multi-center or multidisciplinary discussion with the family from the very get-go. So if you're going to start this during pregnancy, there needs to be a plan in place for what you're going to do after, whether it's going to be breastfeeding or whether it's going to be direct dosing. Like all of that needs to be discussed before you even give the mom the tricaptan. So it needs to be a discussion between the adult doc and the peds doc and the MFM, in my opinion.
Hi there, I'm Angela Delacaris, a PED CF provider in Omaha, Nebraska. I thank you guys so much for this talk. It's very timely for sure with so much that's been going on, and I was not aware of this registry, so I appreciate that. I had a comment and then a question. So the comment was to two of the other questions, and that was about moms who are quite knowledgeable out there, parents, but especially moms who are able to get their hands on ETI. We actually had a patient recently, or a mom and now a baby, that the mom was able to get ETI, found it through knowledgeable ways. She's quite knowledgeable herself, and found a study that was being done in Australia, and then got her OB to prescribe the ETI as no connection to the adult CF center or PED CF center. And we did not get to know about this baby until 2 weeks before her delivery. So the PED CF center then, met the family, did a prenatal consult. But again, that speaks also to the equity of can all moms access that and know about that? So your guys' research is so pivotal for that, so that we can have ways to get this for all moms. But in regards to my question is that this baby was born term, but then had a lot of neonatal respiratory distress. So are you guys able to speak to kind of what we should do in relationship to our neonatal colleagues? They had a lot of questions. A couple of them actually pulled up the neonatal or the ferret kind of model of, is there canalicular abnormalities that occur? And we had to kind of think through, now we didn't even know this mom was on ETI. When did she start it? Could this baby have neonatal respiratory distress due to abnormal kind of neonatal embryology, or is it just withdrawal? So is there anything you guys have on that? And I'll add this patient to your registry too.
Thank you. We have not had other major respiratory distress events reported in detail. So I can't speak very much to the common experience of that. I think it is yet more sobering to find out that someone made it to 38 weeks before coming to attention of the CF center and being prenatally treated. So I think that really makes me humbled that people are out there charging ahead, which I'm excited about. But I think the more data we can gather about these events and outcomes, the better informed we can be in caring for these babies when they do arrive, whether we know about them or not.
Can I ask, was the infant taken off the modulators at birth? Is that what you said? So the mom took it, and then the infant had CF, and when it was born, it no longer had modulators.
The newborn was receiving it through mom's breast milk. So mom was still breastfeeding. So it was still receiving some, but the only thought we could come up with was just that the doses were decreased through mom's breast milk as opposed to the amount the fetus was receiving in utero. Yeah. But the baby was still receiving some.
It's interesting. I've only heard this from one mom, and I'm not sure if you guys have ever heard this, but there was an instance where the mom was planned not to breastfeed or not to take it after birth, and pumped and stored a lot of milk during, or maybe it was like during the first couple of weeks of life, and then was going to stop. And the frozen milk didn't have activity. I mean, the turnover of like the feces that, were rancid and they were obvious, was like almost immediate, like 24 to 48 hours afterwards. And then she started breastfeeding again until the baby could take it orally.
And so go ahead. Well, two things I'll say is there was a French study where they used explanted non-CF mouse lungs and put excessive doses of ETI and did see changes in branching morphology, but you have not seen that in the lungs of your ferrets, I don't think, and they haven't seen it in the CF rat model either. If you saw, if I go back to my slides, so we've seen some respiratory distress, but it's not unusual rates for moms delivering with CF. So we've got, 285 babies who have generally been fine. So we don't think that there's a problem with branching morphology. That study was done in a way that isn't really consistent with how people get exposed.
And do you by chance remember for that newborn, did they have a flag newborn screen or high sweat chloride, any of the kind of newborn diagnosis details that might inform the timing and effectiveness of in utero exposure?
Good question. I know they're homozygous F508, but I don't remember the sweat. Oh, that we'll submit it for you.
Just curious.
Yes, yeah. I think that one part of what we thought was, as in all people with CF and children with CF, could this also be a neonatal complication that we have with neonates? Is it just transient tachypnea as well?
And I think we have a few questions from the app.
Just a couple of last questions. So one question is for the non-CF infants of parents who took ETI, who should be monitoring those infants for toxicity and other lab work?
Yeah, that's a great question and under some debate right now. And actually, there is a group from Brompton who is doing Delphi work to come up with a consensus document about that right now as we speak.
And then a last very nitty-gritty question. What about the dosing? Oh, two questions, same thing. What dosing are we utilizing for newborns for ETI?
So for newborns that I have treated with early access, we have used the weight-based ivacaftor dosing, which tends to end up aligning with whenever drug is received and in hand, and use that component to then extrapolate the other doses. Certain other experts in this room can speak to that.
Thank you all so much for attending. We really appreciate it.